introduction. I'm happy to be here and chat with you all on the economics of vaccination subsidies, incentives, and policies. So as Joel mentioned, I want to briefly highlight that this talk is part of a series. And so I'm not going to cover everything today. So in particular, we have an excellent video recording from last week's presentation that highlights, goes through the science of exactly how vaccines work. And so I'm not going to talk about the physiology of how vaccines work and how the benefits outweigh the risks, but I will look at this from an economic perspective of taking as a given that vaccinations reduce infections and reduce the consequences of infection. What do we do as a society to try to improve societal outcomes? I'm also not going to talk today about child vaccinations, even though that's sort of the latest, the latest approval came out for children. I'm going to focus on adults and the decision to get vaccinated, what are the private costs and benefits and what are the societal impacts of that choice. So I'm going to start by putting us all on the same page by defining what an economic externality is. And then I'm going to delve into COVID-19. What are the private and societal benefits and costs, both of a COVID infection and of a COVID vaccination? I'll talk about what economists view as policy solutions to these externality problems. And then as much as I can, I will pull in research evidence on externalities and how to address them. So since COVID is so new, some of the research I'll present has to do with other types of vaccination coverage disease, such as influenza immunization, and in particular, some work I've done studying the effects of state laws that require hospital workers to get flu shots. I'll show you some evidence of emerging correlations between vaccination rates across states and across countries, and how that appears to be already translating into notable differences in case rates and in deaths from COVID. Okay, so to get started, an economic externality is any effect of a market exchange on a third party. So a market exchange, there's typically a buyer and a seller, but when the transfer of something that someone's buying has an impact on somebody else who was not a party to that decision, we have an externality issue. The most common example of a negative externality is pollution. A firm is producing something that people value and want to buy, but their production process involves, air pollution or water pollution. That is typically not included in their decision making, just like someone who is a smoker has a negative effect on others if they smoke near them and the others breathe in secondhand smoke, but that is not a benefit that the smoker necessarily internalizes. Similarly, your decision to drive to work instead of taking public transportation or biking might make everybody else's commute a little longer because there's more traffic. So all of those are cases of negative externalities. There are also goods that confer positive externalities. Education is one of the main examples. Again, education benefits everybody in society because education leads to better job outcomes, better contribution to the economy at large, better health outcomes. Children fare better with parents who are more educated, and so forth. So what happens when there's a positive or negative externality? We think that the market outcome will not be ideal. There will be too much take-up of goods that have negative externalities because neither the person buying something that was produced in a factory nor the firm making it has any natural reason to consider the cost of the pollution they're emitting into the environment that are shared by all of the inhabitants. So instead, there needs to be some sort of policy intervention to try to account for this problem. So externality problems require some sort of intervention. Examples of how to deal with negative externalities include regulations. So some pollutants might be deemed so dangerous that they should simply not be allowed to be emitted. Smoking is banned in most public areas, indoors certainly, and also even outside near entrances. Congestion pricing is another approach. So some toll roads will charge higher prices to drive on that road if it's during rush hour. These are all ways to try to deal with the externality problem of a negative externality. For positive externalities, it's the opposite approach. You want to make something cheaper. If an education is beneficial to all of society, we make education free, K to 12. We offer help paying for a higher education for people who can't afford it, because the idea is that contributes beneficially and has high payoffs for society. Okay, so turning to contagious diseases. It's clear that contagious diseases impose negative externalities, first for the most obvious reason that they spread. They spread from an infected person to other individuals. So your infection might have a negative cost on you, but it's also going to spread to others, and so that negative cost gets multiplied. Another reason that's perhaps less talked about is that if you have any type of insurance, whether that's Medicare or Medicaid or a private insurance, if you are so unfortunate to have a bad infection that requires healthcare treatment or perhaps hospitalization, you are only going to be responsible for paying a fraction of those healthcare costs, and the rest will be borne by the taxpayers paying for Medicare or the other members of your insurance plan who will face higher premiums in the future. So to give you a picture of how infections spread, epidemiologists have calculated R0 or R0 values for different viruses. And this is meant to estimate on average how many people get infected from one first person being infected. So for the original COVID strain, these estimates were around 2 to 3. So one person could lead to 3 more infections. And of course, this is assuming that they're not self-isolating, that we're not taking protective measures to avoid the spread of the virus. With the Delta strain, which is more contagious, estimates range from 5 to 10. So this infographic has it at 7. Now, this shows you how that compares to other diseases. Measles is at the high end of how contagious it is. Something like Ebola is at a lower end of the contagion. But yes, having a COVID infection is likely to lead to others around you having COVID infections. And what this means is that the marginal social cost of an infection is quite a bit larger than its private cost to the individual. How large specifically? Well, I looked for studies that have quantified this, and I'll show you what is out there right now. So there's one study by a couple of economists who based their estimates on the statistical value of a life. So they were basically considering if you get infected, there's some chance you die, and how bad is a death in monetary terms. There's a variety of approaches researchers use to try to quantify the statistical value of a life. And for this paper, they used the number $10 million, kind of an average range for how valuable a life is. So this means privately, the statistical cost of infection is only $18,000 if you're a rational individual taking into account the risk of death from COVID. But societally, it's at least 3 times as large. And that range is going to depend on what sorts of containment measures are taken to prevent spread. So it'd be on the smaller end if people are masked and not getting together in large groups. It might only spread to a few people in your family that you can't avoid coming into contact with. It's larger if you're going about your daily life and having many more interactions in public spaces. What about the hospitalization costs I talked about? So here are some estimates that have been published for estimated out-of-pocket spending for people hospitalized with COVID. One study found an average of about $1,500 in out-of-pocket costs for Medicare Advantage beneficiaries. It was larger for people under private insurance. Around $3,800 would be the estimated expected out-of-pocket spending. But again, keep in mind that that's only a small share of the total costs of a hospitalization. Here's estimates coming from Fair Health, a nonprofit that collects hospitalization costs from a number of different insurance plans, and they put together estimates for every state. Their Montana averages start at, this is the lowest average, and this is for outpatient treatment. So maybe you had to go to the emergency room because you were feeling poorly and you had COVID, but they sent you home to continue recovering at home. That would have on average a cost of $778. Then for people who were hospitalized, it could range from $38,000 if they did not need ICU treatment with respirators, etc. An average of $84,000 for those who did need more complex treatment. So apart from the chance of dying, which is obviously costly, there's also the chance of surviving, but incurring large hospital bills that are going to be paid partly by you and partly by others. So that's part of the externality cost as well. So now let's turn to vaccinations. Because vaccinations reduce an individual's chance of infection, transmission, and also hospitalization, perhaps the greatest evidence, in fact, is for reducing the rate of hospitalization and death, that means vaccinations carry positive externalities. They protect you. They also prevent you from spreading infection, since you're less likely to get infected in the first place. And they also impose fewer hospitalization costs on society. Let's delve into an individual's decision whether to vaccinate or not. So first, I'm going to outline the private benefits and costs. So this is just what affects you. If you're not thinking at all on whether or not a vaccination is good for society, but you only care about yourself, let's think about the benefits and costs there. So clearly, the largest, the top of mind benefit is that you're less likely to get sick. And if you do catch COVID, you are, there's tons of scientific evidence that you're going to have a less severe infection. You're going to be far less likely to be hospitalized and far less likely to die. That also means, cost avoidance. So you're avoiding potential medical costs of treatment. You're also avoiding the opportunity costs of being sick, of having to miss days of work, of having to, do poorly in your academic studies because you're under the weather for a couple of weeks. So all of that is the personal benefit. What about personal costs? So first of all, there's the monetary costs. Now, in practice, this has been $0 in the United States because vaccines have been fully subsidized. But if there was a price to pay to be vaccinated, that would be part of the personal cost. There's also the hassle cost. It takes time. You got to make time out of your day to get vaccinated. You might have to travel somewhere to get vaccinated. And then in terms of health, there's well-known short-term side effects. So you probably don't want to get vaccinated the day before, an important work deadline, because you know that you might be tired and you might have some symptoms for a couple of days. There's also a risk of very, very rare adverse effects. So those are the private benefits and costs. What about the externalities? So I've already noted a lot of these, but to summarize them in one slide, the first is that you're less likely to infect others, and that's particularly true for the people you are in close contact with. But it's also true that by infecting fewer people, there will be lower spread as a whole, lower risk of new variants emerging, and we'll get closer to what we call herd immunity. So herd immunity happens when most of the population is immunized. Even if some people who can't get immunized for health reasons are still in blue, those people are likely not to get infected even when infection enters this population, because they're protected by the herd, by the large number of vaccinated individuals who are less likely to get and spread the infection further. And then my third point is that we avoid hospitalizations. That saves taxpayers quite a bit of money. One study finds that from June through August, hospitalizations occurring among unvaccinated adults had a total cost of $5 billion. And lastly, but not least, reduced hospitalizations also means better medical care for everybody who is in the hospital for reasons unrelated to COVID or who has COVID. This is just a picture that should look familiar. There's been tons of news articles about hospitals overflowing with patients, putting patients on beds, makeshift beds in the hallways because they've run out of rooms. Okay, so based on just the private benefits and costs, who will choose to get vaccinated? I'm going to argue that it's too few relative to the social optimum, but first, let's consider that there are certainly many people who want to pay to get vaccinated. It's going to depend how much it costs, but we could draw a demand curve showing how much different people value vaccination. And at one end of the spectrum, you've got vaccine tourists coming to America from other countries because they are so eager to get a vaccine that they're willing to buy a plane ticket and travel to do that. Peru is one country that has been very hard hit by COVID. They do have vaccines there now, but it took a while for them to get there. So in the spring, when vaccinations were widely available in the US, an estimated 70,000 Peruvians traveled abroad to go to a pharmacy and get a vaccine. So these vaccine tourists are at one end of the spectrum. They're willing to spend high amounts of money to get to a vaccination. And in the US, thankfully, we didn't have to pay out of pocket for our vaccinations, but many people did drive hours away to be able to get vaccinated sooner when appointments were hard to find in their hometown. So these stories illustrate one intercept of the demand curve where people are willing to pay quite a bit. Who's willing to pay the most? Well, probably those who perceive high benefits. So the people who face the greatest health risks from COVID. COVID is a disease that's very skewed towards harming the elderly. So the elderly, in fact, have the highest vaccination rates, which is just evidence that people are cognizant of this risk. People with chronic conditions and people who are older than 65 have been consistently across states and across countries the most eager to get vaccinated. Now, another group who perceive high benefits are those who internalize part of the externalities and want to take care of the others around them. So some students might say, you know, I got vaccinated because my parents are high risk, or I got vaccinated to keep my grandparents safe, or to avoid spreading COVID to immunocompromised individuals. In fact, part of the vaccination outreach, the campaign nationally to get people vaccinated has been encouraging people to think about protecting their community. But as economists, we realize that people are primarily self-interested, and maybe some of them will do it to protect the community, but we don't want to count on that. We want to think about the individual level private costs and benefits. So here's what demand for vaccinations might look like. This is just a toy graph I made showing that if it costs $600, even at that high price, some people would get it, but not very many. As the price goes down, more people are willing to accept a vaccination. Even at a price of $0, not everybody's willing to accept it, but we're closer to getting to full coverage. I was able to find one study by economists who did a survey experiment eliciting willingness to pay for a hypothetical vaccine. So of course, this isn't, this is a hard question to answer, how much people are willing to pay for a vaccine, but they collected some survey evidence on it, suggesting that in the US, the average respondent was willing to pay close to $100 to receive a vaccine. That was smaller than in some of these other countries, and they did find a correlation with trust in the government. So people who were more distrustful of the government are not willing to pay very much. Okay, so those who perceive the benefits are much higher than the costs will probably choose to get vaccinated, even if they have to pay the cost of vaccination themselves. But herd immunity requires us to achieve higher vaccination rates. For everybody, even if someone perceives a high private benefit, it's probably still true that the societal benefit is larger than that private benefit alone. For people like young, healthy adults who don't perceive much of a health risk to catching COVID, the difference might be particularly large. So this is where we start to think about how we can move vaccinations closer to the social optimum. So if this was the market price for vaccines, let's say it's $20. That's about the price that the government paid. They were able to negotiate a big batch, 100 million doses of vaccines from Pfizer and 100 million from Moderna at a price of around $20 per dose. So what if they had just turned around and said, okay, we're now going to sell these to people at $20 per dose? Some people would be willing to get vaccinated, but the amount of people for whom private benefits are higher than that cost is quite a bit smaller than the amount of people for whom the social benefits are higher than the cost. And this is the quantity that we would view as the social optimum when we're taking into account external benefits as well as private benefits. So who should get vaccinated by this type of analysis? The answer is everyone for whom the marginal social benefit exceeds the marginal social costs. Now, social costs include private costs. So this doesn't necessarily mean everybody should get vaccinated. We know, for example, that there are some people who have had severe allergic reactions to other vaccines in the past, and some of those ingredients might be in the COVID vaccine. So people who have had severe allergic reactions should certainly take pause and talk to their doctors about whether or not they should get vaccinated. They might be in this group here for whom even the societal benefits lie below the price of vaccination. But for most people, the social benefit of vaccination is above the cost. And so this optimal quantity here is much higher than the quantity we expect to get vaccinated in the market equilibrium if people face that $20 per dose cost on their own. So summarizing the economic problem, as with any market where there's externalities, the market solution, the market equilibrium will not match the optimal quantity. In this case, too few people will get vaccinated. There's another intertwined issue here that I'm not going to talk too much about because I don't personally view it as a huge driver of COVID vaccination decisions. But there's a collective action problem we see with vaccination against other diseases like measles. And the problem is that as vaccination rates rise, the disease starts to go away. And then when there's really little measles, for example, then people start to think, well, I don't see anyone sick with measles. Why should I have my kid be vaccinated against measles? I don't perceive it as a real health risk because I don't see it in my community. So that suggests that vaccinations can be like public goods and there can be a free rider problem. Someone might think, I don't personally want to get vaccinated, but I encourage everyone else to get vaccinated because I'm safer if everyone around me is vaccinated. So that's another problem that would compound this. As I mentioned, I don't think it's the number one problem with vaccination uptake with COVID, because COVID is, widespread and prevalent, and we're well aware of how visible it is. So now let's turn to the economic solutions. Anytime you've got an externality and you want to either increase or decrease the quantity of uptake, the first solution that economists will propose is either a subsidy or a tax, depending on whether it's a negative externality or a positive externality. So what we call a Pigouvian subsidy is a subsidy making it cheaper to buy something that confers positive external benefits on others. The goal is to close that gap to start closing this gap between external benefit and private benefits by making it cheaper for you to get the vaccination. So we've seen this done. In particular, we see it because we're not charged $19.50 per dose when we go to get our COVID vaccines. We get our COVID vaccine for free. So this was kind of the first big decision the government had to make about how to increase the vaccination uptake. An obvious choice, if we want people to get this, we should make it free. Not only should we make it free, we should also try to make it as easy as possible. We should try to reduce the transaction costs and the hassle costs as much as we can. So free transportation to vaccine clinics in as many communities as possible. Rebates for Uber and Lyft. The government reached agreement so that Uber and Lyft can take people to their vaccine appointments for free, and they'll be reimbursed by the government, all part of making this difference between private benefits and costs as small as possible. Now, what if that's not enough? What if even with free vaccines, not everybody wants to get it? You could go further. Some states, some local governments, some employers have started offering monetary incentives. Some states started, big lotteries, state lotteries where someone who's vaccinated will earn a $1 million prize. In practice, the results of these efforts have been pretty mixed. And this is one case where I think the solution that seems obvious to economists isn't always the right solution. And we can learn from listening to psychologists and behavioral economists who point out, if you're trying to persuade people to do something that they are a little suspicious of, or that they might worry has unknown risks, it might not really improve their confidence in that action if you're offering them tons of money to do it. That might make people think, why are you compensating me to do something? It must be because it's something bad. So obviously that's not the sentiment that we want to spread. And that could be a reason why monetary incentives for vaccination have had very mixed results. But you could increase the private benefits of vaccination in different ways, in non-monetary ways. In slightly more coercive ways. So in some states, you might see that to go to a concert or to go to a conference, you need to either show proof of vaccination or show a negative test of COVID. So the idea behind those types of policies is twofold. First, it's to make sure that this event doesn't become a source of spread, a super spreader event, but it's also part of making it more convenient to be vaccinated. And if it's more convenient to be vaccinated than not to be vaccinated, that might help move the needle and get more people to get vaccinated. Travel requirements. I've heard of many people who were initially kind of hesitant to get vaccinated, but chose to get vaccinated when they realized that they wanted to travel to Canada and they'd need to show proof of vaccination to do that. And then lastly, I'll mention mandates, which are very much in the news and are a pretty controversial way. It's the most coercive way of increasing private benefits, basically saying that you're required to be vaccinated to attend university or to work at a hospital or to attend a large event or to get into a country to travel. So, of course, most of these mandates, when they're implemented, do include ways to opt out, either showing a valid reason to not get vaccinated, whether it's a medical contraindication or a religious reason. So mandates are pretty much the most effective way to get large numbers of people vaccinated. They certainly have pros and cons in terms of the public reaction to them. So it's worth thinking about when or where it makes sense to have these most strong and coercive policies. it makes sense for them to be implemented in places where the externality costs really are the largest. So where it's most important that we minimize outbreaks and minimize spread. So the first and foremost case is hospitals and long-term care facilities. So this is where the most vulnerable people are, who could face severe consequences of getting infected. And this is also where employees are likely to come in frequent contact with the virus. It's also the case that hospitals are so important during an epidemic that if a doctor or a nurse gets infected and has to stay home and quarantine, that's very costly on the rest of the system. So for all of these reasons, it makes sense for mandates, strong policies to be implemented in these settings. And in fact, as of the present, about 200 hospitals and healthcare systems have announced mandates for COVID vaccination of their employees. Another place where we've seen mandates appearing, and where they appeared pretty early in the spring, is college campuses. Excuse me. So why does it make sense to require vaccines on college campuses? Because you've got young, healthy populations there. You've got people at an age in their life where they, they tend to act in a way that suggests invincibility. So people have small private incentives to get vaccinated, but at the same time, the dense living arrangements and the high number of social interactions in the classroom, at parties, and fraternities and sororities means outbreaks are really likely, and they're likely to go unnoticed if a lot of people are asymptomatic. So over 1,000 college campuses that serve close to 40% of students have COVID vaccination requirements in place. And I believe they all have, some sort of procedure you can go through to request either a medical or religious exemption. And then a third setting that falls into this category where externality costs are particularly large is military service. You've also got the dense living arrangements there, and we rely on the military to maintain national security. So it is a high risk to have outbreaks in that population. So that is one place where we've seen COVID-19 added to an extensive list of required vaccinations that service members have always had to get. Beyond that, the next place to turn to is private employers. And in fact, the government has suggested that they're going to require employers to impose vaccination mandates on their workforces. And we'll see where that goes. I know it's being challenged in some in some courts, it's being challenged. I would argue that there's a continuum. Employers should think about whether their workplaces or where firms are the sorts of places, social hubs, or close interaction contact locations where outbreaks could happen and where outbreaks could be particularly costly. Then it would certainly make the most sense to have a vaccination requirement. The other reason it's in firms' interest to require vaccinations is because many firms are self-insured for healthcare. They offer their own healthcare plans. That means if people choose not to get vaccinated and then end up seeking treatment for COVID, that's costly to the firm, and it's costly to all the members of that firm's health insurance plan. Okay, so in the remaining minutes I have, I'll talk a bit about the evidence for these different types of policies and evidence of externalities. So it's easy to understand when externalities occur. It's less easy to measure their impact, to try to measure the cost and benefits of reducing the externality. Economists have worked on providing empirical estimates of vaccine externalities for a number of different diseases. I have some of the citations listed on this slide. I'll talk a little bit about one of these studies by Corey White, a recent study that looks at flu shots by year, by state, and leverages the fact that in some years the flu vaccine works really well, and in other years it works less well. He leverages that to find some variation that allows him to quantify these externalities. What he finds is that a 1% increase in the rate of flu shot take-up is related to almost 800 fewer deaths, and it saves 14.5 million fewer work hours lost due to illness. So he takes these numbers, does some back of the envelope calculations to get the number of $63 for the social benefits of each individual influenza vaccination, $63 in social benefits just due to reduced mortality, and $87 in terms of reduced work absences. So what this suggests is, the sum of these, about $150 is the benefit of each vaccination outside of the benefit to that own individual. I worked with Corey White and with Emily Lawler on a separate paper where we look at across states and we focus on estimating the effect of state laws that required hospital workers to get annual flu shots. So there's been a growing trend in the past 20, 25 years. More and more states have passed these laws, and many hospital systems have their own requirements, but we focus on state laws for this paper. Some states have stronger laws than others. Some states actually require all hospital employees to either get the flu shot or to wear a face mask during flu season. Others require hospitals to offer it to everybody, and if somebody declines it, they have to at least submit a signed form saying that they declined the flu shot. Our design looks at deaths from the flu, and we specifically use what's called a difference in differences design, which means we're accounting for the fact that flu mortality fluctuates every year. Some years it's a bad flu year, some years it's a better flu year, but that's correlated across states. So our design uses states that did not pass these laws as control states to help us estimate what would have been the likely trends in states that did pass laws if they hadn't enacted the laws. We see evidence of a sharp reduction in influenza-related deaths after these laws. We have data going at least 3 years after the laws in all states, and for some states going farther. And to quantify this, on average, they led to a 2.5% reduction in deaths from the flu. This picture shows the individual estimates for each state's law, and if we average them, this is the difference that we use to compute that 2.5% reduction. So what's important to emphasize here is that the laws are pointing hospital workers to get vaccinated, but hospital workers are not the folks that are at risk of dying from the flu. The deaths are almost all occurring in the elderly. So all of these effects we're estimating are among elderly populations, but they're driven by hospital workers getting their flu vaccinations at a higher rate. So this is evidence of positive externalities, that one person's vaccination protects not only them, but others that they come into contact with. It's evidence of positive externalities saving lives, and is useful evidence as we turn to considering similar policies for COVID vaccination. As of now, there are no studies done that quantify this as carefully as we did because there hasn't been enough time passed. But I can show you a little bit of suggestive evidence looking at correlations that have emerged so far. The Kaiser Family Foundation collected this data of the time period from July to September. So they chose this time period because it's the beginning of the Delta surge, and it's also a time period when everyone has at least had the opportunity to get vaccinated by then. they plot here the population of the percent of the elderly fully vaccinated in each state. And on the y-axis, they plot the deaths of elderly adults per 100,000. So adjusting for population size. And what they find is this downward sloping correlation, suggesting that in the states with higher vaccination rates, fewer people are dying from COVID. This is a statistically significant result. And one way of understanding and interpreting the estimates is that if we group together the 10 states with lowest vaccination rates over here, on average, there were 2.6 times as many deaths in these states as there were in the 10 states with highest vaccination rates. And interestingly, the difference in vaccination rates of these elderly is not that large. It's 76% to 88%. But remember that the elderly are the most likely to be vaccinated in general. So the overall vaccination rates in these states are quite a bit lower than in these states, even among other age groups. And that contributes to this result as well. Lastly, I'll show you a similar picture looking at Europe, where it looks like there's starting to be another wave of infections now. This is a correlation between countrywide case rates per 7 days and the population share that is not fully vaccinated. So because they graphed it in the opposite way here, these are the most highly vaccinated countries where only 10 to 20% are not fully vaccinated. And indeed, they have far lower incidence of COVID spread right now than in these other countries that have a larger share of the population unvaccinated. Okay, so to conclude, I want to highlight a few key points. So my first point is that even though we know more and more now that COVID doesn't often lead to deaths for the young. It can, but it's very, very rare. Nevertheless, I would argue that the private costs of COVID-19 infection are still sizable. There's a risk of hospitalization and very costly out-of-pocket expenses. And there's the risk of damaging long-term symptoms that has occurred to millions of young adults and middle-aged adults are suffering right now. Even though that it's true that the private costs are large, it's important to keep in mind that the social costs are at least 3 times as large. So vaccination is a highly cost-effective choice. On a private level, it reduces risk. But it's also the case that interventions to increase uptake can be highly beneficial to society in helping us get to the point where this epidemic is under control. It's likely that COVID will never fully disappear. It's going to reach an endemic state where it'll be kind of like the flu. And many experts expect we will be looking at taking annual COVID boosters, just like we take annual flu shots, not because we think we're never going to get it, but because when we do get it, the consequences will be minimized. So I'll end with a plea that if you are not vaccinated and you haven't yet had COVID, please consider talking to a doctor about it. Talk to a doctor you trust about any questions or concerns you have. And if you are vaccinated, I urge you to talk to your friends and family about the importance of externalities, about the importance of keeping each other safe. And lastly, just because I always think it's interesting to look at where we are as a county, this is a bar chart of the percentage of Gallatin County residents fully vaccinated against COVID as of last week. So as I stated, in the elderly groups, this is really high. This is close to 90%. But among younger adults, it's much lower. Just over half of the 18 to 29 cohort are fully vaccinated, 63% of the 30 to 39 group, and less than half of the adolescent group. Great, so thank you. That's all I have for slides. I'm happy to take any questions.
Thank you, Mariana. We do have some really good questions, and before you stop sharing, the simplest one might be, do you know which blue dot is Montana on that graph you showed with the different states?
Um, that's a great question. I don't see it labeled. Um, yeah, it looks like they didn't label it. My guess, I mean, in Gallatin County, it is a bit higher than the rest of Montana. I would guess we're somewhere in the middle here with respect for that, for this age group's vaccination. I would guess we're somewhere in the middle. But I'm sorry, I don't have that labeled.
That's all right. I've got, I think, 5 other questions here. I'm going to combine a couple. The first one is, if the coronavirus health outcomes were less severe, how would that change the economics or public cost? And sort of a related question was that too, is if an effective treatment became available for people who got coronavirus, how would that change the economics?
Yeah, so those are great questions. And I've been thinking a lot about an effective treatment being potentially on the horizon, because we've seen that Pfizer says it has an effective treatment, that it's going to try to get approved. I think that if there's an effective treatment, that will make it, the externality problem will still be there because it'll be so much more costly. It's going to be an expensive treatment, and people might not view it as particularly expensive if they have good health coverage. But for society, it's going to be costly to, if people start thinking, I don't need to get vaccinated because I know I can survive with treatment.
All right. The next two I'm going to combine again because they're related. One is, I've heard some companies charge higher rates for health insurance for those who chose not to get vaccinated. And then that was just a comment. And then the second question was, since health insurance pays for part of the costs of someone getting sick, does that change the individual's cost as part of the, I guess, total cost of the disease?
Yes. So for the second question, that's exactly right. That's what I've been talking about as the difference between private costs and external costs. So if I return to this slide that has these cost estimates, let's see. These are the private costs on average. These are the total costs on average based on hospitalizations that have occurred already. This is actually not any different from what we talk about in economics as a moral hazard problem. The idea that if you don't face the full cost of something happening, you might not take sufficient action to prevent it, as if you would when you had to pay that full cost. So yeah, I think moral hazard is there if people perceive avoiding vaccination as less risky, because if they do get sick and need treatment, it's going to be paid for. Can you repeat the first question? Oh, I remember now. So yeah, the other question was about companies thinking about charging different healthcare premiums. I think that's actually a really wise policy. I think that makes sense. It's sort of like companies charging higher health premiums to people who smoke. They're acknowledging that this is a choice, but they're also saying it's a choice that imposes costs on everybody else. So if you take this choice, we want you to be responsible for those costs. So I think that is, I saw some evidence that in some other countries, the national health systems are imposing something like that. And yeah, I would be, yeah, I won't be surprised at all if we see more companies taking that sort of approach here of either requiring vaccination or requiring a higher healthcare premium.
All right, thanks. And this one you might need a crystal ball for, but do you think MSU will require vaccinations for COVID?
Oh, well, so it's illegal right now. I mean, right now, my understanding of the state law is that nothing in the state can be predicated on having a vaccination. So, yeah, I think that's far away. I know the Faculty Senate voted to recommend that. Um, Both MSU and University of Montana have, I believe the faculty senates have tried to endorse that idea of a vaccination mandate, but I don't see it as, I'm not too optimistic that that would happen anytime soon, based on the state legislative environment.
All right, next up here, do you think if the mortality with COVID-19 would be higher, let's say 5% across all age groups, that people would be more willing to get vaccinated?
Yes, definitely. Yeah, I think that, you know, I think people's decisions are largely rationalizable, right? Like in those older age groups where there is a much larger mortality risk, you see much fewer people choosing not to get vaccinated. So, yeah, I think there's some rationality there in younger people saying, I'm not at high risks of dying. This has been overblown. This has been, this isn't really a high risk to me. I think one of the problems with that argument is that we are still learning about the long-term effects of COVID. So a lot of people who don't get hospitalized and don't die still, have lost smell and taste forever. That suggests there's some neurological impact that persists, and many people say we don't know the long-term effects of the vaccine, but I am far more worried about the long-term effects of infection than the long-term effects of the vaccine. So I think it's worth considering that, the viral long-term effects are still a big question mark.
Right, next question up. Would there be negative externalities associated with a vaccine mandate, such as a reduction in workforce?
Yeah, that's a great question. Yes, I think, yeah, so we've seen that is presented as one of the downsides of a mandate is that people might quit their jobs and look for another job. In practice, I don't think the numbers have been as so large to be concerning, but I'm more worried about the backlash from a kind of distrust of the government sort of view. I think there's a lot of ingrained idea that the government is overstepping in mandating vaccination. And so I think that will increase a lot of bad sentiment. I think to some extent, explaining the externalities and explaining the rationale behind those mandates could be helpful, but I still view the largest downside as just people getting angry at the government because of it.
All right, and this will be the last question unless someone else sends one in. Coronavirus is relatively new. We don't have any 5 or 10 year studies sort of post-COVID. Do you think people will change their views about vaccines when there is 5 or 10 years of data that's available?
So it's possible. Yeah, I think 5 or 10 years of data would help us learn more about this population of the so-called long haulers, people who survive the infection but have persistent symptoms of some sort. A lot of them, it looks a lot like chronic fatigue syndrome, and that could have severe negative impacts on the workforce and on people's lives if they end up in that category. I think we have a lot more to learn about how long natural immunity lasts. So I'll mention, a lot of people have already been infected with COVID and see less of a reason to be vaccinated. I think that's perfectly valid, to be honest. I think we should be considering the evidence on natural immunity when considering any type of vaccination requirements. I would hope that showing antigen evidence or showing antibody evidence that you already have those antibodies would exempt you from needing to get a vaccination. In 5 or 10 years, we should know a lot more about how long both of those types of protection work, both from natural infection as well as from vaccines. As I mentioned briefly before, I think the most likely scenario right now is that it'll end up being something like influenza that comes and goes each year, that different strains might change a little bit, and we will be, encouraged to get boosters each year. Places like hospitals might require it each year, but I think that's probably what we're moving towards.
All right, and we did get one more question, so this will be our final one. Do you think the higher vaccination rate in the elderly is purely due to an increased risk of dying from COVID, or is that age group maybe more compliant, maybe because they compare it to the polio situation?
Oh, that's a very interesting question. Yeah, I hadn't thought about that. I think there is really strong evidence that the health risks are most severe for that age group. So I would guess that's most people's main reason, but it could certainly be the case that they are more, they have this historical understanding of how bad epidemics can be and how vaccines can turn things around for society. So that certainly could be. I can't think of a good way to test it or collect an answer to that question, but yeah, certainly good food for thought.
All right, well, thank you, Mariana, very much for the presentation today and being willing to answer questions. We did record today's session. Will be posted on the website with our other ones. And several people are saying thank you in the chat box, and thank you from me as well.
Thank you, everyone.
And we'll be back in 2 weeks with another speaker. Dr. Chris Nero will be our next speaker in this series. So everyone have a great rest of the day.